ये कौन सा है आपका?
Hospitals are significant source of infections, so source control strategies at the hospital level are crucial. Cleaning and disinfection are routine practices in the hospital that are vital for source control, but they are just a part of a comprehensive strategy that is needed. So, what is the involving significance of source control in healthcare? It is not limited to just routine practices, it extends to the prevention and control of various communicable diseases like influenza, tuberculosis, and scabies. And we have seen in the recent pandemic, COVID-19, that has emphasized the crucial role of source control beyond the standard infection prevention and control practices. So its importance of source control is important to know what are the various methods and how can we do it. So what are the 4 Ds of source control in healthcare? First is drainage. It is removal of infection through a controlled sinus or fistula. It facilitates the controlled elimination of an infectious material. The second D is debridement. It is removal of devitalized infected tissue. It helps in promoting optimal healing and preventing further infection spread. Third is device removal. It is the removal of device or foreign bodies that serve as a focus of infection, and it eliminates potential sources of ongoing infection and enhance control measures. So apart from these 4 Ds, there is another fifth D. Sorry. Fourth is definitive reconstructions, which is repairing the damaged tissue resulting from infection or its management. It helps in restoration of optimal anatomic function after source control measures. So apart from these 4 Ds, there is another fifth D, which is demarcation and isolation. So isolation is identification of transmittable infective patients, isolation or cohorting, and then treatment of the patient, and then de-isolation once the patient is sterile. So this fifth D, that is isolation, it is a classic example of a low-hanging fruit in reference to integrated antimicrobial stewardship practices. So what is low-hanging fruit? It is selecting the most obtainable targets rather than confronting more complicated management issues. It needs fewer resources and less effort, and it is cost-effective and applicable to all settings.
Okay. Do I need to follow that? हाइट ज्यादा रहेगा तो ऑब्वियसली में हाथ नहीं आएगा, पर बगल में गिरा नीचे तो आराम से मोल लगा के भी खा सकता हूँ, हाथ भी जरूरत नहीं। तो लो हैंगिंग मतलब एक्चुअली हैंगिंग तो माय हैंड नहीं है। तो एनी अदर लो हैंगिंग फ्रूट एक्चुअली इन द स्टीवर्डशिप डिपेंडेंट एनी वन एग्जांपल काट सकते हैं, हम सब लोग कर रहे हैं। ओके, वेरी गुड। एंड नेक्स्ट और क्या लॉन्गिंग को एक्चुअली हमको करना चाहिए, काम करते हैं पर नहीं कर पाते हैं लोग। एनडीआर आइसोलेशन कर सकते हैं, कोई भी ट्रांसमिटेबल इन्फेक्शन है, एंड ऑल एनडीआर आर ट्रांसमिटेबल। ये आपको जिंदगी मतलब दिमाग में पूरा घुसा दीजिए, कोई भी एनडीआर नाम लीजिए, कोई ऑर्गेनिज्म, ऑल आर ट्रांसमिटेबल। अगर कॉन्टैक्ट से हो सकता है बात या डिपेंड अपॉन द एजेंट टाइप, तो वो आपको आइसोलेशन करोगे तो ऑटोमेटिकली वी आर एक्चुअली मेकिंग ए बैरियर दैट इज डिमार्केशन फिक्सली। So it has many seemed show the data actually after doing MDR isolation from our institute, how actually mortality has decreased. But all this low hanging fruit, maximum low hanging fruit actually tomorrow we will discuss, but still you know mind you have to keep. And I need to बताया और कुछ नहीं है, जिसमें हॉस्पिटल में इन्फेक्शन बहुत रेट कम हो जाएगा। ID2 ओरल स्विच हम कर सकते हैं ना, मेरे पास आईवी एंटीबायोटिक चल रहा है, उसको जब पेशेंट स्टेबल हो रहा है ओरल पहले तो बोले आई कैन शिफ्ट टू ओरल ID2 ओरल स्विच है। और एक ऐसे एग्जांपल हम सब बताओ, और एक नया सिंपल एग्जांपल सेम रिलेटेड टू द एंटीबायोटिक हॉस्पिटल में नहीं देके कहां दे सकते हैं? आउटपेशेंट पैरेंटल एंटीबायोटिक। अगर आप हॉस्पिटल में रखोगे तभी तो हॉस्पिटल का इन्फेक्शन का बात आएगा, जब मैं घर में रखूंगा उसको तो बात खत्म, सब कुछ खत्म हो गया। तो दैट्स ए लो हैंगिंग फ्रूट। and that can be practiced for the each patient as per the requirement. So these are the basic new things, so this OPAT or even micro-oral switch activity or this MDR isolation that we are focusing from our, because ये बेसिक हमने देखा कि हमारे पेशेंट्स के है तो हम कर सकते हैं, पर हैंड हाइजीन तो जैसे गोल्ड स्टैंडर्ड ऑलरेडी तैयार है, we will practice.
Thank you, sir. So what is the rationale for isolation? Infections occur after interaction between host and etiological agents. So if we isolate the infected host, and we can prevent infection to the healthy subjects. So this way we can break the chain of transmission of especially MDR organisms. Source control is an integral component of IMS practices. It contributes significantly to reduce the morbidity and mortality in both hospital and community settings. Transmittable hospital-acquired infections, especially MDR infections with peak organisms, they act as a point source for further hospital-acquired infections and community spread. So this is the first crucial step in controlling hospital-acquired infections. What are the peak organisms, MDR organisms? They are Pseudomonas aeruginosa, Enterococcus faecium, Enterococcus faecalis, Acinetobacter baumannii, Klebsiella pneumoniae, methicillin-resistant Staph aureus, and Escherichia coli. What are the steps to be followed to achieve source control? So firstly, we should do the timely identification of MDR infected patient by involving hospital infection control surveillance team and bedside treating them. Then we should immediately do the isolation or cohorting of the pathogen harboring patients in an isolation room or cubicle. Then we should do environmental deep cleaning of the affected area after shifting the patient. Then we should give right antimicrobial drug in right dose by the right delivery method. And we should take decision on follow-up regarding the duration of the treatment of the patient. Then we should timely de-isolate the patient. Then dynamically creation and coordination of the local ground working team members in that area to master and monitor of each infective prevention aspects we should do. So what are the major infection prevention and control practices of source control? First is contact precautions. These things have already been discussed in the previous session, so we'll read in brief. Contact precautions implemented when there is definitive or suspected evidence of certain infectious agents transmitted by either direct contact or indirect contact. Direct transmission occurs when the infectious agents are transferred directly from one person to another. Example includes by contaminated hands and direct contact with body fluids. Indirect transmission occurs through the fomites. Next is hand hygiene. It is very important, so that is why we are emphasizing on it again and again. So this we have already.
So one thing I just want to ask, like hand hygiene, what is the content of the handwork what we are using in the hospital? Yes? What does it contain? Huh? How much percentage? Yes, in some it's isopropyl alcohol 70%, along with sometimes you have chlorethylene also. So like normally what is distributed is 70% alcohol. So do you know the recommendation, like minimum amount of percentage of alcohol that is recommended by CDC? How much it should be? Is it 70% or more or less? Yes? Like 60%. At least it should be 60%. You can go more than that, but not below 60%.
Thank you, sir. So when should we do hand hygiene? This has already been discussed, and the steps we have already seen. Next is use of personal protective equipments, PPEs, which include gloves, gowns. They should be worn upon entering the patient care area and removed before leaving. Next is we should single use or patient dedicated equipments. We should emphasize the use of single use patient dedicated equipment such as blood pressure cuffs, stethoscope, thermometers and nebulizers. This is not practically possible, but we should try wherever we can. Next is patient placement. Ma'am has already told us we should isolate the infected patient in single isolation room, or if we cannot isolate, we should cohort the patients, in which we should group the patients with similar infections. The minimum spatial separation that is required is 3 feet, And we can use visual color cues for restricted access.
Like in this figure, like you can, this is meant for which type of precaution? Droplet or contact? It is contact only because it's not shielded properly. It's not a separate cubicle. Only what you have, those white screens are placed on that. So this was to prevent only contact precaution.
Thank you, sir. Next is while transfer of patients on contact precautions, we should limit the transfer outside the room to medically necessary purposes. We should cover infected or colonized area during transport to contain infection and remove contaminated PPE and perform hand hygiene before transporting. And we should use clean PPE at the transport destination. Disinfection and environmental cleaning. Cleaning and disinfection of the patient rooms and focusing on frequently touched surfaces and equipment is very important. Healthcare associated pathogens can survive for months on surfaces, emphasizing the importance of environmental cleaning, and removal of colonizers through cleaning is crucial. Then care bundle for infections. Care bundles including evidence-based measures improve the patient care and have greater impact when implemented together. Adapt measures to the local setting, ensure compliance and record and evaluate outcomes. Specific care bundles exist for catheter-associated urinary tract infections, catheter-related blood site infection, ventilator-associated pneumonia, surgical site infections, and Riles tube care. We should follow the specific checklist for these. Body care, skin care, mouth care, and anogenital region care, nail and hair care, and positioning are essential for infection control of the admitted patients. Daily body care contributes to the boosting patient immunity. Then the healthcare vaccination. Healthcare workers should receive appropriate vaccines to reduce the risk of exposure and to spread of vaccine preventable diseases like we have seen, especially hepatitis B that we can prevent. Now coming to approach to source control in MDR peak me cases. First thing is the sample collection. We should send detailed sample cultures to the micro lab, which include the patient diagnosis, symptoms, and antibiotic history on the culture forms. Second is microbiology process. We should identify the organism within 24 to 48 hours and antibiotic sensitivity test results within 48 to 72 hours. We should promptly communicate initial report if growth is observed, and utilize online software to alert the clinicians if there is no growth. Then pathogenicity assessment. We should correlate the organism pathogenicity with area treating team and determine resistant phenotypes. Then the isolation cohorting. We should isolate the infected patient immediately, and after transferring the patient, we should deep clean the bed with sodium hypochlorite 0.5% and send for culture. And prohibit new admissions until environmental culture is negative. Then next is complete isolation. We should maintain isolation until clinical recovery with completed antimicrobial dosing and repeat sample cultures every 72 hours to assess the de-isolation need. Then clinical department protocol. Each clinical department should have an isolation room or cubicle, and we should implement contact droplet and airborne precautions as needed. There should be dedicated healthcare workers managing the infection control information and patient follow-up. And then we instruct the de-isolation after the results are negative for infection. So what are the isolation procedures? We should implement standard precautions at all level of services. Patient is placed in a single room or a cubicle with other similar pathogen and maintain at least 3 feet gap. We should wear clean non-sterile gloves, non-sterile gown and surgical or N95 mask when entering the room, or full PP if airborne transmitted pathogen is there. MDR organisms such as peak may contaminate the environment, including the surfaces and items in the vicinity of the infected or colonized patient. Therefore, barrier precautions to prevent contamination of the exposed skin and clothing to be used. We should limit the movement and transport of the patient and used devices from the room without sterilization. Patients should be moved for essential purposes only with the covering of whole body, and all the healthcare workers entering the area should be appropriate vaccinated. This will help in cross infection. prevention of cross infection. Exhaust fans are to be on each room and cubicle or negative pressure room for airborne pathogen isolation areas should be used. Entry of each healthcare worker to the isolation room to be documented in a register and IPC surveillance to be monitored strictly. Duty roster of each healthcare worker in the isolation area to be fixed for a particular duration with time to time training to them. So these are the various steps for isolation of MDR infected patients. So this is the hospital data after using these practices. This is the data from June 2021 to September 2023, which shows the maximum most common infection in our hospital patients is with Klebsiella and pneumonia. And after using these isolation practices, this we this graph is showing that after using this IMDR isolation practices, the death rate of the patients has increased in the last 6 months, which was around in 40 percentages to 9% and then to 4%. And the discharge rate has increased from 50s to 90%. Another thing we can do is outpatient parenteral antimicrobial therapy. So patient who can be discharged on IV antibiotics in the home, we should use, and this way we can also reduce the risk of NBR infection. So what is the importance of hospital source control? It is an unmet need for life for safety and healthy lives. Hospital source control is crucial to ensure safety and promote health in society. It addresses the challenge of controlling hospital-acquired infections and reducing the healthcare expenditures. It is a low-hanging fruit of integrated AMS practices. Starting point is MDR peak, ME isolation, and isolation of major transmitted infections. So source control is better than administrating various combination of antimicrobials to cure the MDR infection. It is similar to prevention is better than cure. So source control for a patient, it is an old term, an oldest way for controlling an outgoing infection. Purpose is to eliminate the source of infection, reduce the organism inoculum, and correct or control anatomic derangements to restore normal physiologic functions. And for a hospital, what is source control? Its purpose is to recognition and isolation of transmittable infection, control by practicing precautions and right antimicrobial use after right diagnosis or even by OPAT.
That's right. I want to again focus on all of you कि in your practice when you go to a department, please ensure this hospital control part. Individually, I know for each patient you are doing, but that does not solve actually for the community. Because we are discussing it together for the AMR, for the community actually or the global actually pattern how to reduce that AMR. If you think only मेरे patient एक आया है उसमें हम कर लूँ फिर सेट कर लूँ and patient घट है मतलब नहीं वो एक patient तो शायद आपने 20 साल दिन तो बढ़ा दिया but that patient actually now will go to the everywhere and before sterility maintain actually patient goes out and automatically that entire organ goes out. So therefore, this new concept from what actually we are starting, it is an old one, but we are not we have not given any thought process on that actually. For a hospital setting, we are doing HICC, but in HICC, this is another advice from the HICC because only surveillance will not help. Surveillance हम करते हैं उसके साथ this advice we have to give to all the DVC and all the ground activity team for the management of that NDR legislation to isolate it till the patient is sterile. Or patient is actually, if you discharge also, you can discharge and tell the patient don't go and move here and there and transmit the infection. You can isolate home also because COVID no home isolation kitna patient. So therefore we want to keep focus on the left actually table for the hospital setting means for the community setting. So every department definitely will share the guidelines to that every OPAT actually that our department is started from March 2023 we are sending. Previously also we had seen but we are not documented. Now we have a documented process of OPAT. Every patient we are sending and documenting is also following. That same like resident suppose you are also following the OPAT the same month discharge. So why cannot you follow for around 3-4 days one patient will be admitted to IV antibiotics in the home. Patient need a safety network. Yes, मेरे लिए कोई है कुछ आइए देखना कोई इशू हो जाएगा तो मैं इशू कॉल करूँ आपको पता है कि पेशेंट हॉस्पिटल में जाने के बाद उसकी माँ कुछ नहीं करता है पेरिफेरल पता है कि फार्मेसी स्टोर भी जाएगा, वो भी भगाएगा उसको, पीएससी जाएगा तो 100% भगाएगा कि नहीं से आता है। मैंने सिंपल एक आईडी सेक्टर में एक पेशेंट एक्सपीरियंस बता रहा हूं। हमने इफेक्टिव एंटीबायोटिक्स पेशेंट है तो बहुत दिन तक चलता है कि नहीं आई। पेशेंट स्टेबल हो गया, एप्रोवल हो गया, बट फॉर द ड्यूरेशन ऑफ इलनेस आई तो 3 दिन रहने के बाद उसको लोकल बोलने के नहीं, हम तो सेक्टर में इन्फ्यूजन नहीं दे सकते। तो सिविल डॉक्टर हम बता रहे हैं कि आपको कल बताएंगे कि एक्चुअली शुड बी गिवन है काइनेटिक्स से तो कंटीन्यूअस इन्फ्यूजन थी और देना चाहिए। तो नहीं, हम तो 10 मिनट में दे सकते हैं, ले लो, नहीं कम नहीं दे सकते। तो पेशेंट और किसी के पास जा ही नहीं सकता। फिर कॉल आया हमारे जीआर के पास, फिर जीआर समझाया, हमको उससे बात किया, नहीं आप बात करा दो उनसे, फार्मेसी से जो देना चाहते हैं पर जो बात से तो फिर कन्विंस करना है पेशेंट, तो फिर देन एक्चुअली दे एग्री। बिकॉज़ वो फार्मेसी के बाद आपको पता चला कि स्पेशलिस्ट में किसी के पास पहुंच से बात कर सकता है इशू होगा। तो दैट सेफ्टी नेटवर्क आई थिंक एज ए रेसिडेंट वी टू फॉलो।
Thank you, sir. Thank you.
I took this for the employee vaccination to Dr. Smita. Already she was our research person in the first workshop session, so there is no introduction for her. And she is also nodal officer or EHS employee, EHS vaccination. Not nodal. Dr. Meenakshi, yes, sorry, she is another faculty from the CFM, Dr. Meenakshi.
Good afternoon, everyone. As Sir has already mentioned, I have already taken one class on adult vaccination on Saturday in this as a part of observation of this antimicrobial resistance awareness week. So, but before I'll proceed, I'll again express my thanks to Dr. Panda for giving me this opportunity, because gratitude is always worth repeating. So, before I'll go into the details, I'll not take much of your time, because most of the thing all of you must be aware of, but I will only discuss on the things which you need to know or you need to revisit again. So why we are talking too much about adult vaccination, and because my audience is only healthcare professionals, so I'll restrict my talk for them only, not for the other comorbid patients and other. So, because we as a healthcare professional are not only at a higher risk of acquiring infection, but as well as transmitting these infections to our patients. So, at least the best we can do, if you cannot treat, you cannot give any benefit to the patient, at least you shouldn't do anything to harm them. So, the passing the infection to their patient is an important or reason to be vaccinated. So whatever there's an interplay of immune status and risk of infection during our whole lifetime. So what is you can see here is basically in the newborn period, everyone is convinced enough that they are born, they have immature immunity. But as we grow up, but that is not the only thing we can do. As we grow up, and for us, the healthcare professional, we are at a higher risk of infection for multiple reasons, and there are many conditions which actually predisposes us at a higher risk. And after the geriatric age touches, that this immunity against wanes off. So you have to take care of the whole from birth till the last, you can say, the elderly age group. So for the childhood, we have very robust system of vaccinating, at least for the essential medicines are there. There's a guidelines there, and it is very good implementation with the coverage rate for few of the vaccine in 90 plus. But what is the problem is the adult vaccination. We don't have any guidelines, and definitely if there is no guidelines, there is a dilemma among ourselves also what to do. What are the vaccines we should be vaccinated? So, so these are the few of the benefits, just to for the sake of sharing with all of you. This actually not only helps because the last talk was emphasizing on the breaking the chain of transmission, which is very, very important, not as a clinician but as a public health professionals also, because every infection has potential to go beyond the capacity of health system if you will not take care of. And this adult immunization can be of very use for building the herd immunity. And this is very particularly important because, as I already told, that we as a healthcare professionals are there, and the chronic conditions like CKD, cardiac disease, COPD, and so on. And this vaccination can reduce the incidence of vaccine preventable infection. And we need not to argue much about that vaccine is the best strategy or best thing we can do about it, because we have eradicated smallpox disease, which was not only a disease of childhood, isn't it? So definitely the hospital admission will come down, the treatment cost will come down, and the quality of life will improve. Not only the person who suffers, also the caregiver. Okay. So, because we are observing this and trying to make aware people about antimicrobial resistance, so it is also this vaccine is an important tool to prevent the emergence of antimicrobial resistance. How? If the person will not be obviously suffering from disease, will not pass the disease and so on. So, for few of the conditions like we are witnessing Salmonella typhi and pneumococcal resistance among them, this can be a valid tool, because for this actually we have vaccines. For rest we may not have in near future. So what are the vaccines which are recommended? I have taken guidance from CDC guideline, and this is where I always I always visit this site for this, because we don't have any guideline for our own. So for the rest of my presentation, I'll not go into the detail of each vaccine. Most of the I'll try to orient all of you through this slide only. So this yellow part is actually in this chart is the vaccines which is recommended for everyone, and the purple one is there if there is additional risk for that. So as you can see, few of the vaccines are very important for all of us, like this apart from COVID-19, this influenza vaccine. So influenza vaccine, we have two vaccines, live attenuated and killed one. So the live attenuated and because the problem is that if you have to choose where there is immunosuppression, like this is a standard thumb rule, that elderly, and if you are thinking that there's something related to immunosuppression, it is better to use this killed one. Killed vaccine can be used all through, but the live attenuated has to be restricted up to the age of 50 years. And when it should be taken? Influenza vaccine. CDC emphasizes there's a separate program for influenza prevention, and we are the country with the high burden of influenza morbidity. So this is one of the vaccine which all healthcare workers should take is influenza vaccine, and it has to be taken annually. The best time is just before the winter starts, or you can say just by the end of September or the first week of October, and it has to be taken annually. And this after that, the MMR vaccine, 1 or 2 doses. There is a conflicting recommendation for that for this vaccine again. So for MMR vaccine, if there is no documentation for vaccine, we need proper documentation. Even if the person is reporting that he or she was vaccinated for measles in childhood, if there is no document, then we'll consider as non-vaccinated person. And even if the person, for our cohort of those who are working here, most of them are not being vaccinated for mumps and rubella. So for us, the clear cut is that we need 2 vaccines to be given 4 weeks apart. And then another one like hepatitis B vaccine already, I hope all of you must have taken. And then for TD, so previously it was TT, then TD, and now the Tdap. So it is always better to give Tdap, even if it is said even in pregnancy also, where ANCs are also being given TD. But if you don't have TD, then you can go ahead with Tdap if there is no additional what you can say risk there, and there's no side effect as per. So what is the guideline for Tdap? So Tdap should be given again. There's no documentation history. Then you have to give how? You will take one, and then after 4 weeks, and then 6 months, and then booster every 10 years. So those who are handling surgical wounds, for them, the separate thing. What I'm saying is for healthcare workers. So booster is very, very important. I want to emphasize every 10 years. Usually what happens is, what we used to also do it, जब चोट लगी तो एक TT लगा लेते. So that is not required if you have taken this vaccine in such a way that you have taken adequate vaccine for that. And then hepatitis A is one important vaccine. It is very important to take, because very few of us have actually safe, especially those, even if our, like I always quote this, even our overhead tanks in our quarters are, I don't know, I'm not sure how frequently it is being screened and how effective our ROs are. So it is always better to take, even if we think that we have access to safe drinking water. Hepatitis A is one vaccine which all of you can choose to take, because a majority of our residents are in hostel only, no. So then there was an outbreak also. So hepatitis A vaccine has to be taken to again 2 doses. Okay. And then others, apart from hepatitis B, A, and MMR, these other vaccines are also recommended, like for meningococcal B and Hib. These are usually for Indian context. We usually use it for Hajj pilgrims. For healthcare workers, there's no need. They have not yet come. Till now, I have vaccinated 6 people, all for travel purposes. So varicella is one, again, for this is very important for as the person is aging, because at a higher risk of varicella reactivation, because immunosuppression is there. So these are few of the minimum list of minimum vaccination which all of us should. This one I have left is because I wanted to emphasize pneumococcal vaccine, and this is one vaccine which is most commonly being used at our adult vaccination center. So previously we had 13 and 23 pneumococcal PCV 13 and 23. So 13 pneumococcal conjugate vaccine 13 and 23 was there, but now the CDC is recommending 15 and 20 also. So if you have, because it is not yet in India, so there is no point in discussing this, but as a part of, because we have to be updated with the latest guidelines also, so all of you should know that there are 2 new vaccines available in the US, not yet in India, the 15 and 21. And if it will be available, CDC recommends PCV 20. If you have given, no need to give any other vaccine. But if the person has already been vaccinated with PCV 13, which is the most commonly used vaccine in our country, Previnar it comes with the name of Previnar, which everyone is coming with. So if that has happened after 1 year, it is recommended to give PCV 20. So this is all about the vaccination, and I'll not touch. But I hope hospital infection control team must have talked and is doing this hepatitis B vaccination. But all of you have this responsibility also to the one who is joining you. While you interact, you also pass this information. This vaccination is very, very important, and this I have already talked about. So influenza vaccine, varicella, measles vaccine. If you have to give multiple vaccines, then the thumb rule is the same. All the live vaccine can be given in one setting. If killed, there's no need of minimum interval. If 2 live vaccine has not been taken within 24 hours, then again 30 days. For measles, there's a 28 days. For measles containing vaccine, it has to be at least 30 days. There's one, what you can say is, all this thumb rule, there's one exception to this is, even if this pneumococcal vaccine is a killed one, the conjugate vaccine, but it should not be given with the meningococcal vaccine, though it is a killed vaccine. So maybe that I could not find the evidence, but this is the recommendation. So this is, I have already told. Meningococcal, what we are using is only for travel purpose. Then this is, I'll just conclude this. What is happening right now is even if we are not working as because all of you residents are the main pillars of who are dealing with the patients. So this is the number which we have vaccinated at our center between 1st June 2023 to 15th November 2023. And this before this, yes. So you can see mostly it is a hepatitis B vaccine, and this is for patient, not for our healthcare workers. Okay, so all those patients. And the second, which is most common, is rabies vaccine. This is not pre-exposure. This is a post-exposure prophylaxis. Then pneumococcal, and you can see that what I want to emphasize here is Tdap vaccine is very, very less, which is an important area which we need to work upon. And again, MMR is very less as compared to hepatitis B. This may be used as a proxy indicator of the awareness and the motivation of the person, because I am very sure all those clinicians who are dealing with the patient must have written other vaccines also, but because all this vaccine has to be bought out of pocket expenditure, so they have turned up with what they are convinced enough to be vaccinated. So this is, and if you will look for the number of vaccinations, so why these numbers are less? It's not only that is awareness problem. There's some other barriers are also there. So if you will compare this number of yellow fever, because in the yellow fever vaccination center, as a part of adult vaccination, this number, if you will say number, will not convey much of the message, because I don't have very good data for this adult vaccine. I have for the yellow fever vaccine, because adult vaccination I have very limited staff. I can say not limited, only one staff. So the data management was not very, but this number total altogether is definitely 1,000 plus. But when you compare it, this all vaccine combined, which I was talking, compared to yellow fever vaccine, is that this yellow fever vaccine in last 5 months was held only for 15 days. So you just imagine the load. And this vaccine, the adult vaccination, was because yellow fever vaccination is being carried out only on Thursday, and excluding GH, and we had shortage of yellow fever vaccine. So effectively, it was 15 days load, which is being shown here. I'm sorry, 18 days load is being shown here. It is 602, which is a very large number compared to everyday adult vaccination is 434. Apart from that, also the reason why is that yellow fever vaccination is required for the travel purposes to the endemic country, South African and South American. So what are the barriers? This is again, and what you can say is awareness is definitely the most common barrier we think as a for adult vaccination. But even if this vaccine is those who turned up for yellow fever vaccine, they were not aware of why this they are taking it, what will happen. They just wanted this vaccine because they wanted their visa to be processed. So this is how our decision to take or avail some services is influenced, and which is not in other for other vaccines, because nothing is attached to it, isn't it? And they always think about there's no one to counsel enough, because already our everyone is overloaded. So one can prescribe, but motivation takes more time than. So awareness is definitely one problem, but there's other barriers also. So what are that? I consider awareness is not a much problem, but attitudinal barriers are more, because most of us are aware of adult vaccination, even if not aware all the vaccines, how it should be taken, but definitely all of us are aware that as a healthcare professional, we should take adult vaccination, but we are not taking, including me. So why to shy away from accepting the truth, isn't it? So there's an attitudinal problem also. So we need to work on those barriers. And if you will look forward, if you want to what to do as a community, then community need assessment. If you will assess, then only you can plan. And all those barriers, apart from, like for us, those who are working as a primary health centers, the cost is a major barrier, because the person who is not what you can say is cannot afford their medications, how can someone ask to take vaccine, which is very difficult to counsel them and to make them understand, look, if you will be admitted, you will have this much of cost, you will lose wages, and if you will vaccinate yourself, this is how. So we need to do something at a community level, and this can only be done if we will conduct a very what you can say IEC activity with full motivation. And for that, first we have to be convinced enough that adult vaccination is definitely required. Any good work cannot be done in isolation, so we have to do partnership with key stakeholders. Stakeholders from, if you are talking community, from ASHA to the medical officer, and then we have to make a habit, or you can say prevention as a priority. Then only we can achieve adult vaccination. So before I'll conclude my talk, I just want what I am looking forward here from all of you residents is just spend few minutes with your patient, just to advise, just to motivate all of them for adult vaccination, and you also try to get vaccinated. I am also trying my best. Thank you very much.
Thank you, ma'am, for enlightening us with this. Foundation course.
इसको फुली में रखना, ठीक है, फुल स्क्रीन में रखना।
नहीं, ये वाला नहीं है, गलत खोल दिया। ये नहीं, ये ऊपर वाला फिर से नहीं, ये नहीं था, मैं ये वाला खोला था पहले, ये वाला है। हाँ, ये वाला। Now we'll talk about the bundle care approach. What is the concept of a bundle? Several elements which are being done simultaneously. It has to be consistently result. There should be a consistent result in better outcome, greater quality than elements done independently, and systems must ensure all elements apply to all patients, and we should limit the bundle elements. Definition: a care bundle is a structural way of improving care and patient outcome. The care bundle involves grouping together key elements of care for procedures in order to provide a systemic method to improve and monitor the delivery of clinical care processes. What are the interventions that come in the bundle care are, what is WAAP? Ventilator associated pneumonia, and CLABSI bundle is there. What is CLABSI? Central line associated bloodstream infection. Then comes the COTI and SSI. What is COTI? And SSI is सर्जिकल साइज इन्फेक्शंस. ठीक है, तो ये चार होते हैं जिसके लिए हम लोग क्या करेंगे, बंडल केयर करते हैं. ठीक है, सेंट्रल लाइन हम किसको बोलते हैं? इट इज अ इंट्रावेस्कुलर कैथेटर दैट टर्मिनेट्स at or close to the heart or in one of a great vessel which is used for infusion, blood withdrawal और hemodynamic monitoring. ठीक है, वही सारी चीजें जो है सेंट्रल लाइंस में आएंगी. कहाँ से हम लोगों को क्लैप्सी हो सकता है? What are the areas? It can be through the skin organisms. They can be. वो कैसे हो सकता है? एंडोजिनस हो सकते हैं और एक्सोजिनस हो सकते हैं. एंडोजिनस में क्या है हमारा? इट इज बेसिकली द स्किन फ्लोरा. ठीक है, एंड एक्सट्रिंसिक क्या हो सकते हैं हमारे? हेल्थ केयर वर्कर्स के हैंड्स के थ्रू इट कैन ट्रांसमिट. ठीक है, और कंटेमिनेटेड डिसइंफेक्टेंट के थ्रू इट कैन अकर. सेकेंड, थ्रू द कंटेमिनेटेड कैथेटर हब्स. ठीक है, इंडोजिनस हो सकता है by the skin flora or extrinsic, it can be through it extrinsically by the healthcare worker hands. ठीक है, and then third, it can also be through the contaminated infusates. extrinsically किसके थ्रू हो सकता है? फ्लूइड जो हम दे रहे हैं उसके थ्रू हो सकता है, और intrinsically अगर कोई मैन्युफैक्चरिंग डिफेक्ट है उसके अंदर, मैन्युफैक्चरिंग ही इस तरह की सी है कि उसके अंदर इन्फेक्शन था, थ्रू दैट वी कैन देयर कैन बी कॉज ऑफ क्लैप्सी. What should we do for central line insertion bundle? We should hand hygiene, so everybody knows it is very, very important. Then maximal barrier precautions should be done. Full body drape should be done. Okay? Daily review of line necessity. Then optimal catheter size selection and avoid the femorals in adults. Why we should avoid the femorals? Femoral line हम क्यों avoid करते हैं for central line? Why? अरे बेसिक बहुत ही कॉमन सेंस आंसर है. कौन सा एरिया होता है फिमोरल एरिया? कहाँ, कैसा एरिया है वो? वेरी कंटामिनेटेड एरिया है ना, तो वहां से ज्यादा चांसेस हैं कि हम लोग क्या करेंगे, इन्फेक्शन हो सकता है उनको क्लैप्सी का. ठीक है, फॉर दैट वी विल अवॉइड फिमोरल. कौन सी हम लोग करते हैं? विच इज बीइंग विच शुड बी यूज्ड फॉर द सेंट्रल लाइन? कौन सी वेन लेते हैं हम लोग? इंटरनल जुगुलर. ओके, एंड देन वी हैव टू स्क्रब द हब. क्या डूज है हमारे? डेली रिव्यू करना है. प्रॉम्प्ट रिमूवल, अगर कभी भी हमें लगता है कि उसमें कोई भी इन्फेक्शन है, कुछ भी प्रॉब्लम हो रहा है, वी हैव टू प्रॉम्प्टली रिमूव दैट. ट्रांसपेरेंट ड्रेसिंग शुड बी डन. वी हैव टू स्क्रब द हब. देन वी हैव टू यूज 2% chlorhexidine wash, and we have to replace the administration sets. ठीक है, मेंटेनेंस कैसे करनी है हम लोगों को? ट्रांसपेरेंट ड्रेसिंग्स के थ्रू, chlorhexidine impregnated sponges we can use. We have to secure the ports in the sterile towel. And what is the care of site? We have to scrub the hub. ठीक है. Can anyone tell what is the problem with the first photo? क्या problem है इसमें? क्या problem है इसमें? Anyone? This one, this photo. हाँ, very good. Then in the third one, that one, उसमें क्या problem आ रही है? Soiled है हमारा जो, ठीक है? हब जो है that is soiled, ठीक है? ये वाले में क्या problem है? Please be attentive, है ना? In the class, it becomes very boring for the person who is also teaching, है ना? Please be attentive and participate. गलत क्या प्रॉब्लम है? क्या लग रहा है उसमें? पोर्ट कहाँ पे है? क्या है ये? कैसा लग रहा है आपको ये? How it should be? It should be clean ना? और ये कैसा है? Soiled है, ठीक है? नेक्स्ट वन में देखिए आप, नेक्स्ट वाले में क्या प्रॉब्लम है? ड्रेसिंग कैसे हो रखी है उसकी? हाँ, क्या चीज? अब एक माइक दे दीजिए.
She's telling it is not covering and it is also half covering.
Yes, sir. And the last one? क्या प्रॉब्लम है लास्ट वाले फोटोग्राफ में? हाँ, क्या है? क्या वो क्या चीज है लास्ट वाला? इट इज अ नॉर्मल सलाइन बॉटल, है ना? तो कितना देर में यूज करना चाहिए हम लोगों को इसको? इट हैज बीन ओपन एंड कैप लाइक दैट. कितने देर में यूज होना चाहिए? What is the ideal time? Within how much it should be used?
ये बस मैं ये कमेंट किया सेंट्रल लाइन की केस नहीं है.
Then the rate in our hospital, how we will calculate central line associated bloodstream infection rate? The formula is number of central line associated bloodstream infection in a month divided by number of central line days in that month into 1000. हमारा target is 5, and in our institute it is high and it is been increasing. Like we have seen in September, the CLABSI rate has increased to 10, which was 6 in April. ठीक है, तो obviously we are not doing proper.
Okay, the main reason you are thinking, and also I will ask the ground with the residents. You are not putting central line. You are putting central line. And you are also maintaining the line, or nursing officer maintaining. Maintenance by nursing officer. Resident also. Then actually how I cannot resident private because that just as per your HICC any surplus points actually any point why it is increasing last 6 months. Why class is increasing? Because can you show us the figure that was shown?
Which one, sir? This?
Previous figures. The first one.
Yes, sir.
Most of the time people are getting increase like this only. So codes are not covered.
Yes, sir.
Okay, it has been I have observed this also in hemodialysis. Who is now ICN in charge of this CLABSI?
So actually at the time of insertion, maximum barrier precaution is not used always. We are assessing in all the areas, only gloves and gown only. and full tape method is not used all the time. Is only small sheet is used, only CSLB sheet or drugs that steer cover is used. Not maximal direct precaution is used at the time of central line insertion. And sometimes central line insertion is done in emergency only. That's the reason. And in the maintenance staff not used on this program techniques all the times because when we are touching the patient every time we have to use elbow and gauze for that before connecting the fluid or after that we are flushing with the NS. So all the time it's not followed in all the years.
So during dialysis, what the people are doing, they're just opening the cap and cap open ही रहते हैं. They are moving around the whole the dialysis looking for the saline or the Hep saline before closing it. So ideally it should not be done. We should be open only when we are having a heparin or the normal saline in that time. So the exposure time should not be more than 1 or 2 seconds. But the hubs they are usually open for around 5 to 6 minutes.
और कुछ you want to add?
इसमें सर कुछ पेशेंट्स होते हैं जैसे कि हेमेटो वाले पिकलाइन उनको काफी लगभग 1 साल के लिए दे जाता है वो भी रीजन है हेमेटो में क्योंकि उनका भी क्लेप्स रेट ज्यादा है वहाँ का तो ये रीजन है और थोड़े इम्यूनोकॉम्प्रोमाइज्ड पेशेंट है वहाँ पे इम्यूनोप्री पेशेंट भी रहते हैं.
So from this is the observation from the ICN or HIC team. But in the practice, actually, have you put in central you are given? Okay, so you may not have given a central line. Central line, you have inserted. From the initiation to maintenance, apart from actually what 3 major things actually is they told me is the cause of beginning class. For you, what it?
Force is not properly covered. Whenever you use the force, you are getting the cause right.
So once force is out, it will not be freed in again.
And like have to touch the city limit and not flow around and take it actually and
I want to focus on that part also because maintenance definitely we are doing around many long things and during the initial part or during the insertion actually everything should be ready. Like she was saying, in the emergency they are putting what matter actually emergency? But emergency is a department, it is section and everyone everything should be ready in the emergency. Because I cannot tell the CPR I cannot do or CPR I will do wrong because emergency class card is not available. So class card is being made only for the emergency situation, it should be full occupied at everything. So therefore, when you are putting central line in the emergency or anywhere in your ward or somewhere, first ensure that everything should be ready. Otherwise, no matter. Even patient are dying in the emergency, you are not giving the IV or IV insertion. But at least I will not create another MPR only just because patient was in emergency. I have to put the central line in emergency without the sector. In that case, you can put only the long venous line or in any line in the emergency fluid you want to give or emergency medication you want to give, but don't to try the non-hygienic practices. And वो एक बार रह गए तो that in whole life we have to practice that wrong practices. So initiation because scheme is already contaminated or colonized or commensals are there, micrograms are there. Since many patients we are seeing immunocompromised. The same organism will be a part of a colonizer and it will make a pathogen there. And once we are piercing means even if you are not done actually hand hygiene or upon actually the surface hygiene is there and if you pierce the needle, that organism will translocate and go inside, then it is everywhere. So from day onwards actually today, I think this CLAPSI should be 0 because CLAPSI is a major negligence from our side. Like I told you, blood infection, blood cannot be a contaminated or colonized. It has to be real pathogen. Same applies to CLAPSI has to be 0. In COTI there are many things we cannot do. I agree with that. COTI cannot be 100% preventable. But CLAPSI is a part where 100% prevention is there.
It's got to sometimes the organ itself, the whole patient will translocate actually without your negligence also. But should be a shared responsibility for a treating doctor and the nursing staff. So what we have advised our senior nursing officers should take along in the ward, and those patients who are having central line, we should take the responsibility that every precautions to prevent the capture should be taken. Because what happened if we say this thing, but even after several times they are doing the same thing. So and I cannot be present at every time. So it is a same responsibility. So instruction the doctor has to take all the precautions, and why we are using this because for IV injections. So if the nursing officer is using, we should be using the standard precautions, and that should be responsibility of the SLO. Sharing responsibility must definitely.
Thank you, sir. Then the COTI bundle, prevention of catheter-associated urinary tract infection. Indwelling urinary catheter, a drainage tube that is inserted into the urinary bladder through the urethra is left in place and connected to a drainage bag. This is also called as the Foley's catheter. How can the infection occur? First, through the urethral meatus or catheter junction. Second, it can be through the connection between the catheter and the drainage tube. Third, between the connection of drainage tube and the collecting bag. And fourth, by the outlet of the drainage bag. Now the COTI in which we should, what precautions we should do, catheter removal. Think about the catheters in any of your residents. Are the catheters really necessary? We have to look for that. Okay, remove the catheter if there is no good indication for it, and every resident deserves a chance to be catheter free and infection free. That is very important to know. Then aseptic insertion. Only trained personnel should insert the catheters, and we should use hand hygiene and insert using the aseptic techniques. Use the smallest catheter size that will work for the resident and avoid contamination of the catheter. Use catheter securement devices. And we should use regular assessment. Insert new urinary catheter only when there is a good indication, and consider alternatives to use a urinary catheter. Use a bladder ultrasound to guide the management, and we should also implement a process to see whether the residents needs catheters or not. Then the training for the catheter care, train staff, resident and family, and we should maintain a closed drainage system and maintain unobstructed urine flow. Use routine hygiene and do not clean the periurethral areas with the antiseptics, and routine catheter changes, urine analysis and cultures are not required. Then the incontinence care planning, consider alternatives to using a urinary catheter when developing individual resident care plans and behavioral interventions. Remember, no catheter means no COTI. Okay? Then what should be done? Insert care techniques using the aseptic technique I've already told you, and sterile equipments, and maintain there should be a closed drainage system, very important. And we should secure the catheter to the upper thigh to prevent urethral injury, and do daily care of the catheter. Then there should be emptying of the urine bag regularly, 6 to 8 hourly or earlier if 3/4 of the container has been full, and we should clean and disinfect it after each use. Then we have to keep the urine bag below the bladder level. Very important to know that it should be below the bladder level, and we should maintain the unobstructed urine flow and provide patient and family education for care of the patient with the Foley's catheter. Now here we can see what is the problem in the first photograph. Can anyone tell what is the problem in the first photograph? कैथेटर ट्यूब में कुछ प्रॉब्लम लग रहा है आपको? Yes sir. Yes sir, it has been coiled. Yes sir. Then in second one. In second one, how? What is the problem in the second photograph? Sir. Yes sir.
cap is open, and second is also like the way it is being attached. Then in the third photo, oh sorry. In the third photograph, you can see the patient is moving along with that urinary catheter. Then in this one, third one, yeah, this one photograph, it is at the same level. Okay, and another thing to be observed, the quantity. Can you see the quantity? How much it is filled? More than 3/4. No? Okay, and next one. This one photograph. It is touching the ground. Okay, it should be above the ground. Then in last one, again, there is a coiling and there is an obstruction. Then comes the catheter-associated urinary tract infection rate. The formula is how we'll calculate it by the number of urinary catheter-associated UTIs in a month divided by number of urinary catheter days in that month into 1,000. Okay, our target is 2. According to the CDC, it is 1.21 and HAIS says 3.41, while INICC says it 4, but our target is 2. But how much have been? We are approximately close to that. But it was like you can see in April it was 2.37. It was reduced in May, but again it started increasing in June, July, and August, and as well as in the September.
Then what is the most common cause here in our sector? Why it is still more than 2?
For the quarterly, firstly, presence of catheter for the 2 days and with fever. Sometimes we can find that it's because of catheter or not, because symptoms present at the time of admission sometimes. Or second cause catheter care, the mishandling of the urobag, the patient is transferring, urobag is kept on the stretcher, like that.
Any other necessity?
Again, using police catheter for most of the time is not required. We are using it for the collection of the urine only, for measurement, so that it should not be used. For measurement of urine, catheter is not, police catheter is not required. And I found most of the people are doing this.
Yes, unnecessary.
It means the first and foremost is wrong indication. So if that indication we can change, then automatically the number of urine decrease. And adrenal. Patient's relative or adrenal usually do the drainage system, and I definitely all of you agree actually the drainage system will not cannot be done by uneducated people unless we train them. The first 2 days of hospitalization, if every nursing officer or resident actually when taking around, we will give a training to the relatives, because we agree actually this urinary system cannot be handled by our doctor in our mind. Actually, we cannot accept yes, you have to handle the urine, you have to handle the stool, the excreta. So that will definitely be taken care by Indian actually the relatives. Even nursing officer also have some inhibition inside our mind. So that inhibition we cannot remove one day. But definitely we can train the relatives. If you are putting a potty or catheter, it means it is our responsibility to make it is hygienic. Yesterday also I am telling this same thing. If it is a drainage or extension of our normal urethra, it will think also everything will be solved. Even if actually clamsy also, it is just extension of our blood system. Because blood is a sterile system in our body. And if you are making a central line, means the catheter itself is a part of blood system. So when we are opening the cap, it has to be closed, because I cannot open my blood system to flow continuously. Here there is no flow, but it is again can enter through a micro pore only or a micro space. Same applies to the urinary system. If I am putting a police catheter, it means the catheter, whatever the urinary content is there, it is just the extension of bladder or bladder and urethra. So I have to take care of the system, whether in the insertion or with the maintenance. And I think same applies to the WAAW bundle also. When you will see actually we have mental, it is just extension of our endotracheal system. Because if I am actually conscious, then I can take care of my upper pharynx or upper larynx or upper airway part. But if you are putting a extra outside things like mechanical ventilator or intubation, whatever, this is just extension of my system. But patient cannot take care of that part. So as a healthcare worker provider, we have to take care of that extra system we have created for the patient. And I think if all of us will have a conscious understanding about this extension, we can take care of everything.
Yes, sir. Yes, sir. Okay. Yes, sir. Thank you, sir. Then the ventilator-associated pneumonia. It is a subtype of the hospital-acquired pneumonia, which occurs in a patient who are on mechanical ventilation connected through endotracheal or tracheostomy tube for more than 2 calendar days. It is very important to know it is more than 2 calendar days. It is not 48 hours or something like that, which was previously being used. It is 2 calendar days. Okay. How can it be transmitted? It can be through the healthcare personnel or feeding tube, through the ventilator tube device, or it can be also through the fecal-oral migration of the Enterobacteriaceae family. What are things that need to be done? First, we should give the prophylaxis for the peptic ulcer, okay, because the patients who has got the ventilation, they are being at the risk of getting stress ulcers. Daily sedation, vacation, and assessment of the readiness of to extubate should be done. Okay, DVT prophylaxis has to be done. Elevation of the head end of the bed, it should be at approximately 30 degrees. Okay, and dental care should be given to that patient. What should not be done? First, what we have seen in the first photographs, can anyone tell? Huh? What happened? Please be a little louder. Yes, in the first one. Second one, what have you seen in this one? Huh? General measures for the prevention: we have to educate and train. We have to give the hand. We should do the hand hygiene, proper cleaning and disinfection. Surveillance for the VAE, staffing level adequate, and antibiotic rational use should be done. Pre-op, we should ask the patient to stop smoking before the operation, and early post-op mobilization should be given to the patient. The specific measures for prevention: semi-recumbent position, as I've already told you, patient should be at 30-degree elevation. Sedative interruption should be done. Stress ulcer prophylaxis has to be given. Selective oropharyngeal decontamination, oral care should be given to the patient, and DVT prophylaxis. Subglottic suctioning has to be done. Endotracheal intubation, suction catheters, humidification with heat and moisture exchanges should be given to the patient. Then, what is ventilator associated events rate? How we should calculate it? It is by number of ventilator associated events in a month divided by number of ventilator days in that month into 1000. CDC has a benchmark of 6.65, while HIAS doesn't. The data is not available. While in INI-CC it is 13.5 to 19.9. Our target is 5. As we have seen in Clapshire also, here VAE rate is also been increasing. Like it was in April it was 4.59, in May it was 6, then 12, then in July it was 7.36. Now in September it is 15.97. Then comes the SSI bundle care approach. Surgical site infections, they are infections of the incision or organ or space that occurs within 30 days after the surgery or within the 90 days if an implant was placed. What are the 7S for the bundle to prevent the surgical site infection are: safety. We have to say there should be safe operation rooms. Then screening for the risk factors and presence of any infection like MRSA. Then showers with the soap or chlorhexidine, it should be given to the patient before night and morning of the surgery. Then skin preparation with alcohol-based antiseptics such as chlorhexidine alcohol or iodophor or alcohol should be given. Then solution, surgical irrigation prior to the closure to remove exogenous contaminants, and use of chlorhexidine irritant and antibiotic irrigations should be done. Sutures, closed suture with the triclosan coated antimicrobial sutures should be given. Skin closure, skin adhesives to seal the incision, or antimicrobial dressings to prevent the exogenous contaminant in post-op period. Exercise and use of surgical antibiotic prophylaxis. We should administer surgical antibiotic prophylaxis only when indicated based on the guidelines, and 120 minutes before the incision it should be administered, and considering the half-life of the antibiotic, it should be given 120 minutes before the incision. And we have to avoid the prolongation of the antibiotic prophylaxis after completion of the operation, and pre-operative antibiotic prophylaxis should not be continued in the presence of wound drain for the purpose of preventing SSIs. This is the checklist which is there in our hospital. Then the rate formula is number of surgical site infection in a month divided by number of surgery performed in that month into 100. Okay? Benchmark is not being available by CDC, HIAS or INICC, but our target is 5. We are actually, it is very good news that in September 23, now there were no surgical site infection, while in April and May it was like high.
Because we have not
surveillance
from all the surgical site is not taken.
Yes, sir.
Therefore, we cannot take what is our muscular
Actually, yes.
Yeah. So therefore, because this on the surgery we are not doing here. This is just the iceberg part of pediatric surgery. Major surgery is not pediatric.
Yes, sir. Okay, thank you.
Thank you, AHS team, for this detailed presentation and guidance for all the resident how to go ahead. But I will again say to all of you, please use your concise. Please use your concise about actually when any patients or any patients you are treating, just feel it is you only, and if you are disease or person, how to prevent that. Then I think actually every answer you will get. Knowledge aspect, we all have know once you are reading MBBS means you have a vast course of medical science knowledge. Only the common sense we have not increased that. And now we will go to the last part of our presentation about the prophylaxis, because as a MBBS we have to know actually what is the medical prophylaxis and what is the surgical prophylaxis. Because whether you are surgeon or not is immaterial, whether you are a medical physician, it is immaterial for. Because prophylaxis means it is the prevention therapy. So I will request now Dr. Mukesh Vera from the medicine department to tell about medical prophylaxis.
Thank you, Dr. Petta. So, I will discuss about the only medical prophylaxis. Surgical part I will discuss will be discussed by Dr. Amit sir. So, what do you understand about the prophylaxis and empirical therapy? Anybody? And what is the empirical therapy? Okay, so empirical means that patients are already having infection, and we have to start antibiotic before the culture reports to prevent further spread of the infection. And prophylaxis is the okay before getting infection. Okay, so antibiotic. So outline will be of introduction, candidate, who is the antimicrobial prophylaxis, then risks related to antibiotic prophylaxis, antibiotic regime for the IE, RSD, post-exposure prophylaxis, CPT, IPT, recurrent UTI, and take-home message. So I will discuss slightly faster because of time constraint. So we already discussed the empirical antibiotics. Prophylactic antibiotic decrease the risk of development. What are the major disadvantages of prophylactic antibiotic? Anybody? Yes. So resistance is the main development of antibiotic resistance is the main concern regarding the prophylaxis of antibiotics. So in medical, usually we having 2 or 3 diseases it's required antibiotic prophylaxis. One most common is the infective endocarditis. Those patients who having cardiac, prostatic or other things is the infective endocarditis prophylaxis. The specific situation in that mainly in the dental procedure. Other thing is the patient with rheumatic heart disease. They need secondary prophylaxis to develop the second episode of acute rheumatic fevers. Infective endocarditis. Actually, there is a 2 or 3 guidelines regarding the infective endocarditis prophylaxis. One is the AHA, American Heart Association. Other guidelines is NICE guideline. What is the NICE full form? Yes, National Institute is from the British of people use NICE guidelines because American Heart Association is from America. So initially the NICE guidelines say that there is no need of antibiotic prophylaxis in the infective endocarditis. In 2008, they declared that no need of antibiotics in infective endocarditis. Then what happened? They considered that how many patients develop infective endocarditis without prophylaxis. So unfortunately, that years around 45 patients develop infective endocarditis. So they changed the statement. So they changed the statement and they rightly said that infective endocarditis prophylaxis routinely not needed. They use word routinely, but we follow the usually American Heart Association guidelines. So we need infective endocarditis prophylaxis in special situation to prevent or recurrence the infective endocarditis. So who is the candidate of antibiotic prophylaxis for the infective endocarditis? Those patients who having prosthetic valves, or those patients who have previous or relapse or recurrent of infective endocarditis. Then patients who have a durable mechanical circulatory support device. This is a impeller device or cardiac assist device. Those patients who have congenital cyanotic heart disease defect and they needs repair of that patient the defect. Those resolve that, and patient who have passed 6 months after surgical process of percutaneous repair of congenital heart disease with prosthetic material. So these are the potential candidates for the antibiotic prophylaxis in infective endocarditis. So the risk related to antibiotics is we already discussed that there is emerging antibiotic resistance and superinfection. Potential adverse drug reaction because we are extra giving burden to any patients to exposing any side effect of antibiotics. Then you have to see the effect of prophylactic antibiotic. What is the effect? So effect usually we calculate the number need to treat. So we have to the number of need to treat is 476. Means we have to treat at least we have to give 476 patients to antibiotic prophylaxis to prevent 1 case of infective endocarditis. So you can understand the prophylaxis, the value of the prophylaxis. Then antibiotic regime from infective endocarditis, you can simply, especially those patients, those residents who are posted in the dental surgeries, especially tooth extraction, periodontal, major dental surgery. You have to remember this major dental surgeries, you need antibiotic prophylaxis. Then antibiotic not recommended, prophylaxis not in a local anesthetic injection, dental X-ray, treatment of superficial caries, orthodontic application placement, following setting of or setting of deciduous teeth or upper lip or oral trauma surgeries. So what are the major target organisms in the viridians, streptococcus or enterococcus? If you go in the guidelines, when we diagnose that infective endocarditis, usually we have a specific type of bacteria should be culture positive, then we consider the infective endocarditis. So these are the specific organisms we have to target for that. So usually we use amoxicillin, single dose of amoxicillin 2 gram stat followed by before the procedure. If we require, then we can use the extend the antibiotic course. Then patient who having penicillin sensitive, you can use oral clindamycin or azithromycin for the same. The non-dental surgery or non-cardiac invasive procedure, European Society said that they are against the use of prophylaxis antibiotic in case. So, some specific procedure such as respiratory procedure. So, target organism should be Staphylococcus. So, what is the drug? Usually we use cephalosporins. But usually in respiratory procedure, we do not use the antibiotics. Only antibiotics, prophylaxis antibiotic used in the dental procedure to those patients who are having high risk of infective endocarditis. But in respiratory procedure, if you want to use, you can use the cephalosporin. Then GI surgery or genitourinary respiration, you can use what target organism and what antibiotic use should be. Remember, just remember the what organism you have to target and what antibiotic you should be to select. So target organism in case of urinary tract urinary genitourinary procedure, usually we consider E. coli, gram negative. So what is the antibiotics we usually use? Amoxicillin or cephalosporin. Then skin, you already know the skin and soft tissue always cause either Staphylo or Streptococcus. So you have the drug of choice because of emerging resistance of MRSA. We usually use directly vancomycins. Then cardiac implanted device infection, then you have to target the Staphylococcus and coagulation negative Staphylococcus. So recommended is cefazolin 1 gram IV if low MRSA. If you prolonged surgery required, you have to do the vancomycin infusion. Then coming to the RSD prophylaxis. In the rheumatic heart disease, usually use secondary prophylaxis to prevent the recurrence of rheumatic fever. So, why we need the RSD prophylaxis? Because of rheumatic fever, usually we have to prevent the secondary infection and secondary insult of the heart. Not only the suppose one patient having acute rheumatic fever, if you not giving that person to antibiotic prophylaxis, they may spread to other person. And second thing is the patient already having some cardiac illness. If he develops acute rheumatic fever, then the insult will be increases. So that secondary prophylaxis is important for the RSD. So simply remember intramuscular benzathine penicillin 1.2 million unit every 4 weekly, means every 21 days. So you can start benzathine penicillin. So why only benzathine penicillin? Anybody? Benzathine penicillin is nothing. Penicillin, add the benzene ring in the penicillin. So what is the difference between the long acting and short acting? So those rings who are adding in any substance, they increase the half-life. So similar in the insulin, if you add more rings in the insulin, that will become the regular long-acting insulin. So similarly, we need long effect or long half-life, then we have to use the single benzathine penicillin. So penicillin, when we give you, we have to use the sensitivity testing. So you need a short-acting penicillin before that giving the long-acting dose. So usually we use short-acting penicillin as a sensitivity dose. Then you can give the long-acting penicillin. So how long the continue rheumatic? So you remember 5, 10 and 10 and lifelong. So 5 means patient develop acute rheumatic fever without any carditis. So what is the carditis? Anybody can see? In acute rheumatic fever, there is an inflammation of all the layer of the hearts. Pancarditis means the infection of the endocardium, myocardium and pericardium. So there is an inflammation in the pericardium. Usually patients may develop in the acute rheumatic fever. But when the patients came out from the acute condition, usually patients do not have any lesion. Most of patients. Some patients may have either rheumatic heart disease like that, mitral stenosis, or some patients having mitral regurgitation. That means the patients having residual lesions. So those patients who develop only acute rheumatic fever, not having any residual lesion on echocardiography, they need only 5-year treatment or 5-year prophylaxis, or they attend at least 21 year age. Because of after 21 year age, the patients who the risk of infection is less in Indian settings. Most commonly, IE occurs in the patients who are residing in crowding place. Then second is the patients who have acute rheumatic fever in the past. Now patients having some residual lesion, those require 10-year or as the attend of it as of 21 year. And those patients who having permanent or chronic cardiac problem, those patients came in the OPD with those echo-finding of chronic RSD with severe MS or severe, those requiring at least 40 years, or according to WHO, they need lifelong treatment. Then in those who was resistance to the or allergic to penicillin, we can simply give the erythromycin or azithromycin once a daily dose. Then coming to the post-exposure prophylaxis, and those patient, those healthcare worker who received the exposed with HIV positive patients. So this is the fluid or exposure to body fluid. So which is the infective, which fluid is the non-infective. You can just remember that blood, semen, vaginal secretion, several of the synovial fluid are the infective, and tears, sweat or urinary feces not infective until otherwise they don't have visible bloods. Okay. So this is the first step. I think everybody know. Then when we decide that patient required prophylaxis or not prophylaxis, then we have to decide what is the exposure code and what is the source code. So exposure code, if you having fluid flask, then you have to the small volume, then exposure code 1, large volume exposure code 2. Then in intact skin, no prophylaxis required. Then you have to the injury, type of injury. If there is a less severe, exposure code 2, and more severe or when patients having hollow bore needle deep injury. This is the very important. You have to remember why it is important. I will tell you later. Exposure code 3. So you have remember the exposure code 3 is very important. Why is this important? Then you have to the what is the source code? Source either HIV positive, maybe the less viral load, or HIV positive with high viral load. Or third is the unknown. Source is unknown. Then this is the recommendation. If you come, one is the exposure code. Exposure, if exposure code 1 means EC1 means patients having some exposed with some fluid, only fluid, some small amount of fluid. So if you just remember 3 and plus 3 or 3 plus is required prophylaxis. So if you see in the last row here, 3 exposure code 3 means patients having large bore needle exposure. Source is either less positive HIV1 with less viral load, or so needs that. Then coming to the here, exposure code is 3. If source is unknown, you have to need prophylaxis. In case of if patient is high risk, those patient, suppose patient dialysis पे है, उसको एक्सपोज हुआ है, आपको नीडल इंजरी हुई है, तो those patients are very high risk because of in recurrent transfusions, or those patients who are hematological malignancy, they need recurrent transfusion. These are the high risk patients, so you have to need the prophylaxis without knowing the source. So this is important. Then TLD, every patient who having either treatment or prophylaxis, we usually TLD. Tenofovir not use, if you can't use in tenofovir in children, we can use the other drug, either abacavir or anything else. There is various anti-HIV drugs in the NACO guidelines. So follow up, simply you can remember 2, 4, 6 and 8. Then other either CPT prophylaxis and IPT prophylaxis. So co-triazoxole prophylaxis, what is the primary prophylaxis and where we can use secondary prophylaxis. So co-triazoxole used in primary in the patient to prevent PCP, prevent TB, prevent the cryptococcal infection, prevent the secondary prophylaxis for TB, PCP and cryptococcal infection. So not only the we can use the PCP for cotramazole, typically isoniazid, and secondary prevention of cryptocurrency, we do use fluconazole. Then coming to the IPT. So isoniazid usually we use as a 300 milligram plus pyridoxine 50 milligram daily for 6 months. So eligibility is the all adults who having negative 4S symptom. If they are having positive 4S symptom, then what we to do? We have to do the screening for tuberculosis, and if they found active TB, we have to treat. So we at least we have to give the 6 months of IPT therapy. So what is the IPT? Isoniazid prevention therapy. Anybody? History TB. Or is treat latent TB. What is latent tuberculosis? Yes. So IPT is only for the TB. Suppose some patients having already tuberculosis and he has taken ATT for 12 months. So or he need to treat IPT therapy. No, because who already treated with tuberculosis because of, so he or she not. Then coming to the antibiotic prophylaxis for recurrent UTI. So you just remember the definition of the recurrent UTI, please. The more than 3 symptoms of lower UTIs in 12 months and more than 2 symptoms in UTI less than 6 months. This is the only one guideline recommendation. This is not routinely used. Please just remember, this is not routinely used. So drug of choice is just nitrofurantoin, single daily dose, or trimethoprim. Okay. So I think we need antibiotic prophylaxis only in this situation. We should understand empirical and prophylaxis of use of antibiotic. Empirical antibiotic and resistance is the drawback of the prophylaxis antibiotic. Potential adverse effect is the other side effect of the antibiotic. Thank you.
Thank you, Dr. Mukesh. And I'll request Dr. Amit Tyagi from the Department of ENT Surgeon to have final words for the surgical prophylaxis.
Nice. This one. Please. Follow my idea.
So I is being given the responsibility of saying the final word. So but consider it as the last but not the least topic. May I know, should I understand my audience is how many of you are resident?
Green color.
They are can be without. Okay. So and senior as well? Senior? Yes, FR also? Okay. So this is the last presentation. Are you expecting it to finish fast? Or shall I wrap it up for you? Or what is your no, say it. I think I should know. Come on. What is in this? I am supposed to give the final words. So anyway, I will try. Don't worry. Okay, I'll try. So one thing I will start with. I think all of you know about the story of Alexander Fleming. Are you aware? Anyone who is aware? Who can discuss that story? And that story has one message. So the story goes like this: that Alexander Fleming was working with Staphylococcus aureus, and he just was frustrated what he wanted to know about those colonies, and he just took leave and he left that dishes of Staphylococcus aureus, just left it in one corner and went for a leave. And he came back after that. And all of you know, I think, what he saw. he saw that a mold, white mold, there is a fungus grown in one of the petri dish. And he was surprised to see that all around there was no colony of staph. And the more periphery, the outer ring of that, there was staphylococcus. And the famous statement, what he said, like Eureka, no? The famous statement, he said, oh, it's funny. He said like this, it's funny. So that's how it started. The fungus. Penicillium, at that time rubens, later it was found it is notatum. Okay, so that fungus. Now just see the wonderful nature. How wonderful nature is this. Just tell me how amphotericin B, which is antifungal, how do you get it? You are getting penicillin antibiotic from fungus. Now amphotericin B, which is antifungal, you are getting from no. You are getting from closer. So I do not see the face. So what is that? That is bacteria. That is bacteria. So we are getting antifungal from bacteria and we are getting antibiotic from fungus. What is bacteriophage? So can you see this? The nature. Nature, they are living together also, but they are killing each other also. That is nature. There was always contradictory forces working in the nature. Now the question is, antibiotic, as the main topic here is antibiotic resistance. We are not talking about here antibiotics. The concern here is actually antibiotic resistance. No, the whole thing is about antibiotic resistance. In that antibiotic resistance, the topic has come of antibiotic prophylaxis, surgical prophylaxis. Correct? Now, penicillin, when it was discovered, soon after, it was in fact the manufacturing, it was started later. 1920 it was discovered and after 1940 only it was produced at a mass scale. Now, resistance of penicillin was developed only once you start taking antibiotic, correct? Now, penicillinase producing bacteria. Do you know when was it discovered? Tell me when was it discovered? It was discovered by the same team who discovered penicillin and it was in 1940. So now understand, you are getting actually penicillinase producing bacteria before giving penicillin to the mass population. So it means there is something, now we have a chicken or egg problem. So we have a resistance first or we have antibiotic first. So what do you think now? Which is first? Huh? So do you think that antibiotics were not there before? Pre-antibiotic era when you say, do you think that antibiotics were not there? Huh? Naturally. Naturally was which one? But which one? Which one is naturally producing, naturally present this thing, antibiotic? Okay, so let's come to the first slide. So tetracycline goes and actually deposited in bones. So there were bone remains which was extracted, and they found this in skeletal remains, tetracycline, by more chemical methods also. They must be knowing better. So this was tetracycline was found in skeletal remains before Christ, BC. So from where it was coming? It was coming mainly from this particular Sudanese Nubia. They were actually having the habit of storing grains, and in that there is a actinomycetes. They used to fermentation of those grains, and it produces the tetracycline.
and it has been also found at the nearby colony where they found another skeletal remains. If tetracycline was not there, and actually when they saw the strength of bones, it was found that they were much better. So somewhere this naturally occurring. So now again question came, which came first, chicken or egg? Which one? So now there is another concept is coming up now. Resistome. Are you aware of this? Resistome. So they say that actually in nature there is already, like Darwin and Lemma, that example you must have seen that giraffes were there, short neck, broad neck. Now, according to Darwin, both were there, and according to Lemma, when harsh economic ecological realities were there, then it increased. So now we know both are correct. Because genetics also plays a role and epigenetics also plays a role. Correct? Epigenetics also has a role. So epigenetics mutation, when you are giving antibiotic, it is also causing a lot of this thing, resistance, and other phenomena is also happening because these kind of bacteria already are prevalent in soil, in nature. And now what's happening when you give antibiotic, they become kind of a propagate themselves, like by the Darwinian force. Because when you kill one, the other one will. And the Darwinian forces, when they go, they become like a monster. And gradually it is happening. Gradually the resistome, which is more prevalent, because they are fighting day and night with the harsh realities of this, whatever is happening in the soil, stones. So this is the same thing happening. Now what we are getting in the return by giving antibiotics left and right without thinking about what we are getting not superbugs, we are getting monsters. And they are all around us. And this phenomena you can see here, pre-antibiotic era. Okay, so this is a pre-antibiotic era. When these children had TB, they were supposed to lie in one open listing, and the only treatment was fresh air. So now they are saying that we are again going back to pre-antibiotic era because no antibiotic is going to work after some time. They say that from factory, whatever effluent does, antibiotics factory, whatever effluents are coming out, it is 1,000 times more potent than what MIC you need. What usually you give, it is more 1,000 times more potent. And that means it is so dangerous to the environment. So it's not about hospital. Now it's about the environment also. So this discussion actually is not in the hospital, it is outside also. And what about antibiotic here, where we are discarding? That discarding thing also where it is going. So the situation is very grim. Actually, if suppose we go in pre-antibiotic era, at least they have fresh air. But we don't have fresh air also. So there is no hope. Now fresh air also we are taking from our earth. So that is the situation. This is not working very slow. And I will send. So all of you know that antibiotics changes the whole paradigm of treatment. All of you know. So there is no point of discussing. Itself you can understand before World War, it was like 45 years. That was the life expectancy. And now we are having 85 years. But again we will go back to 55. So next. So anybody who knows what is entitlement? It can be surgical regimen, right? उनको तो पता होना चाहिए, हाँ? Who was the father of modern surgery? हाँ? मम्मी पापा के बारे में पता होना चाहिए. This is not good. Okay, so this person is very famous, and he in his colleagues. And he was the one who actually started the concept of antisepsis. And everybody when they say no, it's a colloquial term, antiseptic. क्या है antiseptic है? Botulinum cream antiseptic. वो cream antiseptic. But this antisepsis term actually propagated and actually in practice done by Joseph Lister. You should know about this person and this phenol carbonic acid which we see in hospital, and I'm always very much from my childhood also I like this smell. Some people they don't like, and that's why I became doctor actually because of this carbonic acid. So this is a Paul Ehrlich, this and Alexander Fleming. Paul Ehrlich. I'm just discussing because until you know don't know your history, you will not have that interest in the subject. Paul Ehrlich. Nothing? Nothing about the Paul Ehrlich. What is the magic bullet? Magic bullet. सुना magic bullet? Picture का नाम नहीं. It's not a Hollywood movie. This stuff was given by him. And this magic bullet means that it is a kind of bullet which only kills the bacteria, but not the host. And this is the person who first in this asked this. And then antibiotic concept gradually coming. And Alexander Fleming, we already talked. But I said that there was one message in Alexander Fleming. What is that message? Always take lead if you want to do get something. So always trying to get lead. Now, this is all history. I don't want to go into this in the last time of the day. It's not the final word. Now, why we want to discuss about surgical prophylaxis? You know, the most common organism of this is this. So always bacteria, virus, fungus, they are culprit. But you know, there is one word also, healthcare associated infection. So the most common organism of infection is not bacteria, it's a healthcare worker. So now healthcare worker and most common HAI, the reason is SSI. I don't want to go again into this because it will not come into the final words. Cost and all of you know that this is a major problem. And the way we give antibiotics, forget about in COVID times, RMPs, in our hospital also, the protocols are not being followed, not because we don't have good intention, but because we don't have knowledge, awareness, and the zeal of that thing, perseverance that until and unless we work on this, a good habit cannot be formed. Yes, I hear that about the lines, no? It is a continuous effort which should be put by, because if you have developed one habit, you will not realize. Subconsciously you keep on doing it until you consciously work on that. So I think in abroad and all, if you go, you will see that culture. That culture is already there. And we need to work on this. And it's not difficult. Yeah, please. So I don't want to go into this also. We will discuss this also. Now all of you know that intrinsic and extrinsic, both factors required. But because when you talk about if you give any antibiotic, it doesn't mean that you forget all the other things about the comorbidities, about the hygiene, about the hand wash. So those cannot be substituted. People think no. Sometimes I have heard this discussion in war. हर एक को करनी पड़ता है इसको हायर एंटीबायोटिक देना, है ना? तो ये कॉन्सेप्ट इट्स अ डेंजरस कॉन्सेप्ट. तो फ्रॉम बिगिनिंग पॉइंट कि चलो दूसरी चीज नहीं हो रही तो इसको हाई एंटीबायोटिक दे देंगे. नो. Prophylaxis, all of you know why we are talking about prophylaxis. This surgical health, you know about that classification, class 1, class 2, class 3. It's a very simple. You just don't have to worry about this. Clean means you are just inciting the skin or somewhere in mucous membrane and you are going into the soft tissue. Okay? And the bacteria is not inside, it is in outside, which is getting entry when you open. So these are all cleaning surgeries because bacteria is not inside. Okay? So clean bacteria like in ENT it is Therapeutic. Okay, simple. Now, clean contaminated. What is this? When you are going into the genitourinary, alimentary tract, okay, respiratory tract, but under controlled condition, okay, like laryngeectomy, okay, all those things. Contaminated when you become in uncontrolled. Uncontrolled क्या होता है? Accident से open हो गया deliberately. Accidentally pharynx open हो गया. Neck dissection कर रहे हो, neck dissection में pharynx open हो गया. So these are all contaminated और जो dirty है, infected है, those are all where the necrotic tissues are there. So it's simple, no? Clean, contaminated, dirty. I don't think so. It's a difficult thing. And rate as you go, it is increasing. There is nothing, and there is no point on rectify this. This is superficial incision, SSI, deep incisional SSI, organ SSI. Organ, you know, the whole layers is involved. When superficial means subcutaneous tissue and muscle and fascia. You always know that mesoderm is fibrous layer. That's all you need to know. Whenever muscle is involved, it is visual. Upper superficial, the whole thing is deep. Now, I just going to talk about this, and that's all. For which patient should SAP be administered? Right. So, clean surgery should we give? Huh? Every case. That's what I'm saying. When intrinsic factor, extrinsic factor, both you need to think. Yes, you need to put. But there are some conditions. What about when you are putting implant? What about you are having 6 to 7 lakh inside and you can't take chance? What about immunocompromised patient? Okay. What about prosthesis? So all those things you need to put. Now, so clean there is no need, but in these conditions you need. Clean contaminated? Yes, you need. But other, there is no point. You have to manage because there is already infection is there. And what is the principle of this in surgical prophylaxis? The reason is that there is no infection. Now, when there is an infection, body will react with what? Inflammation. So, instead of body giving a job, why don't we give antibiotic before itself? So that body will not get a job, and that job will be done by your prophylactic antibiotic. And that antibiotic also will not lead to microbial resistance also, because you are giving only 1 or 2. Okay. Now this is the clean surgery. As we know, this is a stab. Most common is gram-positive tocari. So cephalosporin, as already discussed, you can give. And most commonly, if you don't know anything, it's a cephalosporin. Most common antibiotic. But again, as a surgeon, you cannot rectify everything. You need to see the whole thing: patient factor, environmental factor, ISO factor, तुम्हारे resident factors. Resident factors also must. How are they? Because whenever I just give any antibiotic, I always ask who is on call.
So I will give a comment on that resident factor because it is a live experience on me. When my first child get born in just 4 months before through our LSCS in the OT, and I asked actually why you are giving this before LSCS any antibiotic, and after that also 5 days antibiotic. And because you are telling OT is the highest standard where actually the infection prevention is taken care. And I am as a ID person also, I know that there is no need of antibiotic. So then the surgeon actually told, yes, it is our resident factor. So that I remember, then I thought it will be remember for my whole life, because my wife got 6 days, 5 days of antibiotic for the clean surgery.
So other thing also happens is the problem with this all RCTs, evidence-based medicine, they are sometimes not context specific. And when you follow the RCT and EPM in your area without doing research in your area, then sometimes you are bound to fail. It happens.
Because sometimes you think that these protocols we just apply in our patient also, and just you see the miserable things. And we have seen when we just give prophylactic antibiotic, and when patient, because the standard also should be, everything should be increased. Anyway, but we need to follow this, we need to, because to follow this, we need to do that. So that's why we should put our efforts into this. Now, when should SAP be administered? Now, as it was said that it should be within 120 minutes before slide, but ideally it should be within 60 minutes. But when you're giving vancomycin or like vancomycin, it should be given in infusion. So then you can follow 120 minutes. Okay, chloroquine. Then you need to follow this thing. But otherwise, 60 minutes is this thing. If you're giving capacity, you can give 5 minutes before also. But there is no point of giving antibiotic once you have put the NC. कभी कभी ऐसा होता है एनेस्थीसिया वाले भूल गए, सर्जिकल रेजिडेंट भूल गए, और जब इंसी लग गया तो कोई पूछता है एंटीबायोटिक दे दी, हाँ दे रहे, और कोई नहीं मना करता उसको. There is no point. Now the time is gone. Now body has to react. How should the dose be chosen for SAP? Only one dose. There is no point of giving 2 or 3 doses. However, if your surgery is, again, when you say one thing, in medicine there is no absolute. Always remember this thing. In medicine there is no absolute. You have to think each and every point and never make any formula of it. So, single dose, but when your surgery is prolonged or your antibiotic, the simple formula is half-life. If it is more than 2 half-life of your given antibiotic, then you need to give second dose. And maximum 12 hours. Okay? Now, this is the same thing, or if major blood loss is there. If your loss is more than 1.5 liter, sometimes it happens in many surgeries, then you need to repeat it. Then, even in clean surgeries, you need to give. Suppose something complication happens, and it is more than 1.5 liter, you need to give. Okay? But actually, by that time, it is too late. Again. Should the SAP be prolonged after the surgical intervention? Answer, no. Okay. If you are going to do this, you are developing microbial resistance. So that is again one more thing is just that clean and contaminated food. What kind of antibiotic you give? Because one place you gave cephalosporin, but now there you are opening the genitourinary. As discussed, why we don't put femoral vein. Because in minor area there are possibility of intestinal bacteria, like even the gram-negative bacteria. So now initially in clean there was gram-positive profile, but here there is a gram-negative bacteria. So you need to know where you are working, and again the same thing. Now you need to suppose the HICC says that in your hospital, in your OT, Klebsiella is more common, and which is resistant to this, and susceptible, sensitive to this. So now your prophylactic antibiotic will not be simple cephalosporin. It should be what HICC is recommending. So it is not fixed formulas. You need to understand each and everything, and then we will decide. So I hope this lecture will be some useful to you. It may form some templates in you, which will you go back and just follow this. But remember the message. Take lead.
Thank you, Dr. Amit, and this last presentation, but it was interactive, so I think we have not slept. Any questions? And we have the interaction group. I just ask. In that group, you can message. I can contact to the Dr. Amit and he will answer.
So if you are putting a tunnel catheter in dialysis patient, they are immunocompromised. Tunnel catheter, central line.
Okay.
So that catheter costs around 26,000, and regarding the vein also, we will having 4 veins in the neck. And we need to visit the vein also. Should we give the antibiotic prophylaxis in these patients? Or putting the tunnel catheter?
Then then it's a different story.
Right.
You are talking about IGP.
Yes, IGP.
I don't know. Because it will come into the pain, but immunocompromised, your question is
The
immunocompromised.
patient is immunocompromised, CKD is
So it's
immunocompromised.
not a proper incision. No?
Yes.
It's just a needle entry. So I don't know because
I need to get a tunnel also, sir.
it depends on how much big incision you are going to put. If you're going only by needle, IV line, I don't know IV line they put or not. Because IV line, prophylactic antibiotic, is there role? I don't know.
So normally we are not giving, but since depend upon the prolongation, actually suppose incision actually site because it's a tunnel actually, you want to make a tunnel through the subcutaneous tissue after it. So
But the same thing is this, so you are going through one hole, no? You are making a tunnel in subtube, but staph is in just above the hair follicle. And you are going below. The only thing is, yes, one thing important, sometimes you make a tunnel wrong, where you go through the hair follicle. If you are going through hair follicle, it's staph will come in there.
indirectly actually answer also is not clear, it is a gray area, but if you compare with the pacemaker insertion, because they are actually also going through a tunnel actually the permanent pacemaker insertion. So in that they given the American Society of Cardiology, they also advise actually for the during permanent pacemaker give a single dose of antibiotic. So in that way, answer is actually you should give if it's immunocompromised because you are putting a prosthesis like things, and it will be stay for a prolonged period because it will make also colonizer of the organism there. So since pacemaker is the same thing, even with the temporary pacemaker and same things. So in the immunocompromised state, you should go, and but it is a gray area; it is not evidence.
Suppose IV line you are putting, and if patient is immunocompromised, ideally are we supposed to?
No, because you are staying for the 3 days maximum or actually 2 days like that thing. But if you are staying for the prolonged period for more than 2 weeks, usually it is taken for prolonged period.
More than 1
months. More than 2 weeks.
I didn't come through across in any literature, so I can't say.
We will search again and we'll come to a conclusion. And
one question I have.
Yeah.
I can ask.
Yeah. Now resident can answer.
Okay. When I was going through, my question is, we are talking about the antimicrobial resistance, but I just searched our literature also, but the time was not in we can answer. When we are giving 1 or 2 antibiotics, like we take, so there is chance that resistance develops. Okay. All of us say that you should take antibiotic full course, but here we are giving 1, 2 or 3 antibiotics. Why this prophylactic antibiotic not produce resistance? What is the reason?
No, it is not like that actually. It will produce resistance only. Once, because if you are inhibiting once giving antibiotic means to the body, it will kill the microbiome, first concept. Whether it will kill the organism, pathogen actually is immaterial. Even if the non-pathogen, like commensal, colonizer, it will kill because it has its property to kill the organism. So once you are killing some normal microbiome, what you are telling the first, so another microbiome will grow up with a resistance property. So that actually in the morning also you are telling when patient we are treating here and patient discharging home, with the patient is in the discharge condition and patient recover, it is a MDR infection. But patient take that organism and change of microorganism and goes to a community. Then in the community it spreads. Therefore, community acquired AMR or MDR patients now increasing rapidly. We are seeing actually Dr. Mukesh also will agree in the ICU. Directly we are seeing patient coming with 5 days of fever with a MDR pathogen of community acquired pneumonia, or it is a urinary tract infection as a part of septicemia with septic shock. So what is the cause of that? Main cause is they have taken MDR infection from the hospital, not them, they are surrounding actually who are actually patient got admitted. And that microbiome change because of antibiotic, whether it is a prophylaxis or in a normal way also. So answer is always yes. It is already clear-cut evidence whether you use prophylactic or single dose of antibiotic also, because that will change your microbiome, and that microbiome is constantly interactive in the community.
So resistance anyway will
100%. Thank you for all for the patient for this 30-minute delay session today, and tomorrow we will finalize actually to be right time we will complete that. Tomorrow we will focus more on part of the PKPD, our body apparatus. how our body behaves with actually this antibiotic when it comes. It is essential for all of us. And I hope all of you come in the right time in the tomorrow. And just fill this post survey because this is the mandatory one. You can fill in your home. You just take a snapshot. And the same thing what when you entered to the house. And because this more than 75% passing mark we want from this post survey exam. Pre-survey we have given or not, that is immaterial for me. But post survey is mandatory. I will share this screenshot also in the interaction or group. Now we take a photo. You just stand up from that only and take photo, and we'll go with the research person.
So